Good afternoon, everyone. Welcome. I'm Craig Snyder, the president of the World Affairs Council of Philadelphia. I'm going to start with our always repeated admonition here. If you haven't already done so, please take a moment to silence your cell phones. We do, however, encourage you to join the conversation about today's program on Twitter by tweeting about today's event using @WACPhila. And we also always invite you to like the World Affairs Council on Facebook, where we now have over 1,050 likes. We're coming up in the world. In case you did not see your email from us this morning, because you are on your way here, I'm proud to also announce the launch of the Council's mobile iOS app for Apple devices. The app, which is free to download, will let you stay up to date on our programs when you're on the go. You can make reservations, you can listen to our radio show podcast, and we'll be adding functionality and information as we go. We are the first World Affairs Council in the nation to offer such a tool, and for those of you who are Android users, that version is shortly to follow. We'd also like to let you know that we still have a few seats left for next week's historic event, and that's not an exaggeration, at Congress Hall, which will be the first ever event from that landmark building to be live streamed on the internet, and is part of the Stan and Arlene Ginsberg Family Foundation's Great Debate series. Stan is with us today. As always, we thank him for the support of that important piece of the Council's programming. This event at Congress Hall next week will take a look at the state of the American presidency, and we will be debating with our speakers what constitutes greatness in an American president. We're glad to have you all here to join us at lunchtime today as we discuss a topic that has been so much in the news and on people's minds recently, that of Ebola. While you have surely heard about the crisis, and the spread of the virus, many, including those of us here at the Council, have questions about what is true and what is more mythological, if you will, about what we're hearing and the gray area between those things. So we have with us this afternoon Dr. Edward Jasper of the Emergency Medical Department at Thomas Jefferson University Hospital. Dr. Jasper heads Jefferson's Bioterrorism and Disaster Preparedness Center, which provides continuing education regarding disaster preparedness training and exercise. Dr. Jasper joins us to discuss the realities of Ebola and other communicable diseases, and also we hope to dispel perhaps some of the falsehoods that you may have heard in other places. Please join me in welcoming Dr. Edward Jasper.
Thanks for having me. So I'm primarily an emergency room physician at Jefferson. That's my day job. And I do emergency management for the hospital as well. But I have a lot of outside things that I do. I'm the medical director for the state disaster response team. I'm the acting medical director for the federal DMAT team. I chair and co-chair many committees locally and nationally. And I've taken about every training program you can take, including donning and doffing of personal protective equipment in Anniston and a number of others. And I've conducted exercises around the country for pandemic preparedness, including Pennsylvania's in 2007. And so, why do I say that? Am I an expert in Ebola preparedness? So, good and bad is no, I'm not. It's bad because it would be nice to have a real expert, but it's good because the reason I'm not a real expert is we have not faced recurrent epidemics of Ebola, so that we've learned from those experiences. So the answer really is there are no experts in Ebola. CDC is no expert. How many epidemics or pandemics even of Ebola have there ever been? And the answer is none. So what do we have experts in emergency management? I tend not to be critical of people's responses to things we've never seen before. So people in Florida are experts at hurricane preparedness. There are people in Israel that are experts, unfortunately for them, at suicide bombers on buses responses. But really, other things we really don't know. We do our best. And I always like to quote the Prussian field marshal from the late 1800s who said, "No battle plan survives contact with the enemy." We really don't know what Mother Nature and what terrorists are going to send our way. So we don't have experts. in this. We have people that are good thinkers and they try to work through the plan, but we know we're going to get curves thrown our way. So I just came from Penn, where there were 4 congressmen present asking people from our region to give their input into what our levels of preparedness are and what we need and what hasn't been addressed. And I never know what I'm going to say on Ebola. I've lectured many times on Ebola in the last few weeks, as you can imagine. I have no slides, because every day I change the way I'm going to present the Ebola talk. And I didn't really even know what I was going to say today until the train ride in. And I was thinking that I'm going to talk to the 4 congressmen and get a chance to tell them what I think the issues are. So in emergency management and emergency medicine, you really have to look at the bright side of life, right? Because otherwise you can be dragged down by some of the things we see. So this topic is called the bright side of Ebola. And let me tell you why I'm calling it. So I'm going to start with the story of pandemic preparedness. Just generally pandemics. Forget Ebola for now. We have dodged bullets on pandemic generation after generation. So if we just go back, forget the great plagues of ancient history, but let's talk about the 1918 pandemic plague, right, of influenza. Killed 20 to 30 million people at least, more so than World War I itself. And it was somewhere between 2.5% and 5% case fatality rate of people that got it. And influenza typically affects 20% of the world population. So a pandemic of influenza that has anything other than the way less than 1% that we normally have for seasonal influenza has a lot of case fatality rates. So that went away. We had some scares of influenza after that didn't amount to very much. And in 1980, we had HIV, right? So HIV, do we have a vaccine 35 years later for HIV? No. So people say, I will just get a vaccine whenever a disease pops up. It's not that easy. A lot of Mother Nature protects itself and defends itself from treatments and vaccines and changes and mutates. So it's a difficult disease to treat. And so a couple weeks ago in the ER, I had a homeless person with HIV come in. And not everybody who presents it are heart attacks and things. And all he wanted was something for itching for his mosquito bites. And I've taught all along with HIV that if it was mosquito-borne, like malaria, life on Earth would be considerably different than it is today, right? It's already the worst, one of the worst pandemics we face, over 25 million deaths, HIV, but you cannot get it if you don't do certain things. But if it was easily spread in the air with mosquitoes, it would be a much different story. And we had SARS in 2003. SARS is airborne, more easily transmittable in many ways than Ebola. Well, there were 8,000 cases of SARS. For those of you that were paying attention to SARS back then, it was, again, 2003, it didn't last that long. It was a coronavirus, a new type of virus we'd never seen before. So when the disease broke out, no one knew what it was. It took a few weeks to define it. And at 8,000 people, 800 deaths, 10% case fatality rate, 2 to 4 times that of 1918. And it just stopped. I don't know why it stopped. No one knows. So there were public health measures in place and things like that, but generally it's hard to stop an airborne disease just with general isolation, quarantine type things, but it just went away. We know it still exists in nature. I just saw an article recently on some bats still had coronavirus, SARS virus in them, but that was another shot from Mother Nature just as a warning, right? Then we have bird flu, H5N1. It has up to a 60% case fatality rate. The good news is it's limited spread person to person. The bad news is in ferret studies, which is a model for influenza transmission for humans, ferrets transmit to each other similarly to the way humans do. It was discovered that it only takes 3 mutations on the H5N1 virus to make it readily spread in the air between ferrets. So do you think that should have been published? Big debate went on a few years ago whether those genetic changes that you need to make it easily airborne transmission should have been published, because one, it's good, scientists could study it better, and the other downside is terrorists could take those mutations and create a much more dangerous H5N1 bird flu virus. So there was a debate, and it was published in journal Nature, or main journal. So the mutations are out there. But we're dodging bullets with H5N1 for now because it's not easily transmissible human to human. Otherwise, if it becomes that way, and it's a seasonal influenza virus, let's say it becomes transmissible like that, with 20% of the population of the world getting it, and instead of the 2.5% that we had in 1918, we had a 50% case fatality rate, it would be by far the worst pandemic in human history. We dodged a bullet. Well, before Ebola came around, we had MERS-CoV virus in Saudi Arabia, Arabian Peninsula. And that's affected a few hundred people. It's a coronavirus like SARS. It's another SARS in the Arabian Peninsula. Very high case fatality rate, more than SARS. And it's airborne. But it's not easily transmissible person to person. There were cases this week in the Arabian Peninsula, and there have been cases that went from there to other countries. We had 2 cases of MERS-CoV virus from travelers from the Arabian Peninsula in the United States in May. It just stopped there. They were isolated and it went away. No treatment, no vaccine. Even from the 2003 SARS, we have no treatment, we have no vaccine. These things are not that easily treatable. And in February, there were a peak of cases of H7N9 influenza in China, 40% case fatality rate. Not much different than the Ebola disease. It went away, a couple cases in the last month, but their flu season is like our flu season, and everybody's worried that maybe they'll start getting a lot more of those cases now that flu season's upon us. And influenza viruses can exchange information with each other. So maybe one of these viruses will become a global pandemic, much worse than an Ebola outbreak. So the bright side of this, right, it took me a while to get to it. Now you're all not going to want to sleep at night. It took me a while, but now we're at the bright side. The bright side is we are not prepared for a pandemic, and Ebola is helping us become prepared, finally. And Ebola, look, it came out in 1976. That's when it was found and spread to humans. Back then it was Zaire, now the Democratic Republic of the Congo, by the Ebola River in Zaire. So it's Ebola Zaire is what we currently have as our strain. Well, since 1976, there have been about 6 outbreaks in rural areas of Africa, and they were controlled because they were rural Africa, they had some public health infrastructure, and they just went away, because it's not easy to spread to each other. The problem with the current one is it's infecting countries that really have no infrastructure. Liberia has been in civil war for decades. They have no public health infrastructure. They have ritual burial practices where people wash the bodies all together before burial. They don't trust government. They stay home. They have no health departments really per se to even go to, or hospitals. And this is very important, it affected an urban area, not a rural area. So it's spreading out of control there, but even out of control there, a few thousand cases. Now maybe it'll become, worst case scenario, 10,000 a week, whatever the predictions have been, maybe 100,000 a year. We don't really know that. But the fact that there aren't hundreds of thousands already tells you how hard it is for Ebola to spread. So it is spread, as far as we know right now, by just close contact. The fiance of the guy who died that was in Texas, she's not sick. None of the casual contacts of anybody that have gotten it have been sick. The 2 cases of the nurses, they got it because they had very close contact with the patients. They had feces, vomitus, things that they came in contact with, and they didn't have full body PPE, personal protective equipment, that everybody's using. And so likely they somehow inoculated themselves. They were taking care of a patient for long hours at a time that was very infectious. And close contact meaning changing sheets that were fecally and vomiting on the top of those, where we know this disease can be transmitted. But for now, no one who has gotten sick has spread it to someone that sat next to them, touched anything that they have. So we're lucky because it's not spread that way right now. Could it mutate? Sure. Could a terrorist try to send a bunch of people to get Ebola and then come into this country to deliberately spread it around? Sure. And we think about those and try to prepare for them. So it may change, but for now, it's not spread that way. We had MERS-CoV virus cases in the United States. We didn't get a big epidemic of MERS-CoV virus. We had SARS cases in the United States, airborne. Didn't spread in the United States because we have a public health infrastructure, and they're not easily spread. And Ebola is not easily spread. So, but the thing is, it's created panic and fear, which is right side and bad side, right? That's the way I look at everything. So bad side is you don't like panic and fear, that's not good. But the bright side is it lights the fire under people to start thinking about things. So last week I was at a meeting with City Council. They created a committee to look at our city's preparedness. Today it was congressmen, look from the federal perspective of our preparedness. What do you need? What can we get you? What kind of problems do we have? And I told them I was going to come to this meeting, and I'm titling this The Bright Side of Ebola. I told the 4 congressmen that were there. And I said, because you're here, and I get to tell you what I think we need to do for pandemic preparedness in general, and that this is lighting the fire. After 2009, we had H1N1 influenza. I don't know if you remember much of it. Because at first when it occurred in Mexico, it looked like it was going to have a significant case fatality rate. Everybody was scared. We were getting a bunch of personal protective equipment. And it turned out to peter out. It was nothing, less than 1%. It was even less than typical seasonal influenza. But it pointed out that if we tried to order more masks, like N95s that we use for face protection, we couldn't get it. Everybody was ordering. There was a shortage of supply. There was all kinds of issues identified in 2009 that we weren't ready. And after that, bipartisan panels were set up to look at the federal and hospital response to 2009 H1N1 influenza. And universally, there were failing grades across the board for everybody. And not a lot has been done since then to get us ready for a pandemic. Not Ebola. I mean, Ebola is not the global killer. It's not going to bother us in the United States. Unless something changes and it mutates, we're fine. We're going to have a few cases. We'll have a few more in Africa. And the issue is really to fix it in Africa, more so than here. The fewer cases there as it gets conquered in Africa, we won't have to worry about it here anymore. But yeah, we'll get some cases. There's no question a few will slip by. But it's not going to spread like crazy. But what it's doing is raising awareness of our lack of preparedness for pandemics in general. Ladies and gentlemen, that is huge. Because if you had to do a hazard vulnerability analysis and say, what are the biggest risks to the world? And what's the most likely thing? And what's the greatest impact it's going to have worldwide? We have lots of issues, global hunger and all kinds of other things. And I'm in an MPH class right now, and my class is global health. So I got to study Liberia in detail. But the issue is pandemic has hit us and fired warning shots our way, Mother Nature. It can be the greatest thing in the world or the worst terrorist there ever was. We've gotten all the warning shots that I just told you about. We weren't doing a lot about it. But Ebola is making everybody do all kinds of things. Hospitals, negative pressure rooms to isolate people, all the levels of PPE, every level of government, including CDC, to revise the way they looked at these things and to give them not fear, but the respect that they deserve. So that when, and I'm not saying yet, when the next pandemic comes out, and our human history is just full of pandemics, I'm confident that we're going to be much better prepared for the next thing that comes our way as a result of what Ebola has done for us. And that's really the take-home. We're not going to have a global outbreak of pandemic of Ebola unless it changes, but we are going to be better prepared for the next pandemic. And that's the good news. So thanks for your attention. They asked me to talk for 15 minutes, and then questions?
So just a couple questions from me, and then we'll open it to the audience. So you talked about negative pressure rooms and the other kind of sort of high-tech approaches. There's been a lot of these news reports about there being only 9 or 10 of the sort of highest level of care beds available in the United States, and presumably the American infrastructure is as good as any and better than most. So is that 9 or 10 number accurate, and what should that number be to be prepared in the way you're talking about for a potential much greater pandemic risk?
Thanks. So the beds they're talking about are federally designated infectious disease centers that have been funded to handle anything, not just Ebola. So they have negative pressure rooms, anti-rooms, labs inside the room so they don't have to send blood out elsewhere. So there are 4 of those federally designated centers in the country. But really, it's just an illusion of they're the only ones that can do it. We have 20 negative pressure rooms in our hospital and 4 in our ER, for example. And what they do is they take the air from the room, they exhaust it through HEPA filters, and then out through the outside air, so they're not recirculated within our HVAC systems, our own ventilation systems, and they're filtered through HEPA filters. And we put airborne diseases in there. So measles is an airborne disease, tuberculosis is an airborne disease, and TB is the greatest killer in the history of mankind. And it's still a big problem worldwide with antibiotic resistance to TB. A much greater threat in a lot of these countries than Ebola is, just like malaria is, and just like starvation and hunger is, and all the other things that affect them. So there are just a limited number of these designated federal hospitals with a limited number of beds in each, but we have been treating people that were airborne infectious disease that nobody wants, like TB, forever. And our preparedness has been going on for many years. I have 250 of the Papper motors and 2,000 of the hoods for pandemic preparedness that I bought 10 years ago. And so I didn't need to order anything for this. I ordered some stuff just to back it up, But if all the orders are blocked because we can't get them, which is the case, just like 2009, lessons learned, you can't get things when everybody else wants it. But I don't need them. You know, we have plenty of stuff, and there are other hospitals that are already prepared as well. So no, we could handle a dozen Ebola cases just at Jefferson, and all the major hospitals could do the same thing if we had to. It would be a problem because we'd have to get everybody suited up in these high-level PPE. Patients would be afraid to come to Jefferson because we have Ebola cases just like they saw in Texas with 30% or more reductions in volume and ED volume. But no, that's not, that's what the media says, but no, hundreds, thousands around the country could be taken. Every hospital, every major hospital could handle a number of these cases, not just 8 or 10 beds.
Okay. Myth dispelled. What's your position on this debate about a travel ban from West Africa to the United States?
So I'm a medical doctor in disaster preparedness. Traveling to and from a country is not my area of expertise. But I'll only comment this, that complete travel bans, and I'm speaking as a student of the Masters of Public Health Global Health class that I'm taking now, that really screening properly, I would say non-essential travel, sure, don't go to these areas. But there are plenty of countries. We haven't banned travel in Saudi Arabia. We didn't ban China travel when they had H7N9. Those are all airborne. I think really calm heads prevail in these kinds of things. So proper screening, definitely screening more so than untrained people using thermometers and saying that that's good enough. When 13% of people don't have a fever with Ebola in West Africa, that's by CDC's own data. So screening isn't going to get everyone, but careful tracking of people that are leaving these countries, talking to them, getting histories, making sure they're at very low risk. For now, that's the way to do it, I think. And every time a disease pops up in a country, putting total bans, if that became the model for Ebola, we would have to do that everywhere, every time a disease popped up that we don't like. And so I don't think that's feasible. Non-essential travel, sure. Don't go on vacation in Liberia this week. I would probably say that's a good idea. And other than that, cool heads prevail.
Okay, last one from me. You talked about the priority really being with respect to Ebola to stop it in Africa. The president announced the availability of up to 3,000 American soldiers, mostly combat engineers. Do you think that that's the right approach? Is it a direct U.S. Intervention to build up the infrastructure?
So, great question. I like it, and it's because of the challenge that it poses for us. So, what do we do in countries that can't take care of themselves? And we really should have something better in advance while we're trying to fix these countries, which is a global health problem that I talk about every week in my class. So we can't fix those countries' problems overnight. And so there should be not a U.S. approach to this, but there should be a global approach to controlling outbreaks in countries that can't take care of themselves until we build up the infrastructure so that they can. And in countries with civil war like Liberia, that's a very difficult task to undertake. So unfortunately, we don't have that yet. And I think, the bright side of Ebola, I think that's going to be something that comes out of this. That we're going to start looking from a world health approach, looking at how we can come in and go in. Everybody's identified a lesson learned from this is that it wasn't handled on a global scale soon enough to control the outbreak. Had we sent a bunch of world resources, and I don't know the United States should always have to be the leader in this and send all our resources. This should be a global countries that can helping the countries that can't. If we had gone in earlier, we probably could have nipped this in the bud, so to speak, earlier, and you wouldn't even have me here today. It would be over, like the previous outbreaks of Ebola occurred. So no blame. I never blame anybody for something we should have done in a disease we've never seen before. That's not fair. But the next time, then you can blame someone for not doing it again. And I don't think we're going to make some of these same mistakes again. Right side of the wall.
Questions from the audience? In the back, please.
One of the very unattractive aspects of the Ebola so far has been the way it has been politicized by both sides. So I'm not sure how frank you can be about this, but after talking to the 4 congressmen this morning, were you encouraged or discouraged by their response?
Well, I do believe that Congress should talk to me before they do anything or say anything. Since that really hasn't happened. They do their politics, that's what they have to do. But I felt that there was genuine interest to get back to Washington and relay some of the messages that we gave them. And it wasn't just me, it was representative of other hospitals, healthcare organizations, health departments, EMS. It was a broad group of people presenting our concerns. I think they genuinely were interested, and I talked to them about the bright side of Ebola, just like I did here, and they should take this back and look at it for global pandemic preparedness. And I think they heard. So yes, there's always a political side, but this seemed genuine.
Was there consensus among the group presenting to the congressman as to what the needs are?
I think so. I mean, we gave it from different perspectives, but one of the needs was to maintain funding for hospitals and infrastructure, because that's been reduced. Every time there's a major bad thing like 9/11, our funding goes up for disaster preparedness. And then as they have to look for things to cut, that keeps getting cut, and that's been happening for hospital preparedness as well, significantly. About a third cut last year alone. And so the message was to stop doing that, because we use those dollars to buy our personal protective equipment, get our infrastructure up to speed and maintain it. It's not something we have seen, so we don't get pandemics every year. So to maintain preparedness for pandemics is pretty tough. Last year I used the money, for example, to buy radiation sensors for people that walk through in case we ever get a dirty bomb, which would release radioactive dust, right? So how many dirty bombs with the release of radioactive dust have ever been detonated across the world in our history? None, absolutely none. So who's the experts in dirty bombs, right? Nobody. So if they cut our funding, it's another of the bright side of Ebola, right? It's likely going to help reduce the continuous reduction in preparedness dollars we get, because now we have a disaster, now everybody has heightened awareness, so they're going to be much less likely to cut funding to the things, and probably will increase it again. And I don't think Ebola is going to be a huge issue for us unless it mutates or changes. Nobody's getting it from people that have Ebola. It doesn't seem to be easy to transmit.
Please.
In your judgment, how great a threat is bioterrorism by non-government groups?
So terrorist use of bioterrorism agents. Huge threat. And so when we look at what are our greatest threats, so anthrax, for example, is called by our federal government, it's really the poor man's nuclear weapon. Because you could take anthrax, release it over a city, let the spores blow over the city, and you could kill as many people as if you detonated a nuclear weapon. That's the whole point of the BioWatch sensors that exist in cities. We have sensors in various cities looking for the release of biological agents from a terrorist group, just for that reason. And those filters are checked every day, and we look for the release of bioterrorism agents. Every so often one goes off with like plague or something like that else, and it's just a natural occurring disease, but they check them and culture them every day. Within 36 hours, we would know in all of those major cities if someone released the bioterrorism agent. So Ebola, the Yamashimikyo that attacked the subways in 1995, the sarin, well, in 1993, they sent 16 doctors to Zaire back then, now the DRC, to try to get Ebola samples to bring back this weaponized disease, and they weren't successful. So absolutely. Bioterrorism, creating these weapons. Smallpox, when there was the Soviet Union and we were in a Cold War, for decades, we had competitive bioweapons programs. And the Soviet Union made like 40 metric tons of smallpox every year. So that's not a vial of smallpox. And so their equivalent of CDC, Vector Labs, still has smallpox, just like CDC still has smallpox. It's one of the great things about humanity. You know, we look at it, there's a lot of bad stuff, let's face it. But there's some unbelievable greatness in humanity. We did what Kennedy said. We got to the moon and returned safely to Earth. And what the World Health Organization said, we're going to conquer smallpox and eliminate it from the face of the Earth. I said TB was the greatest killer in the history of mankind, and it's still on the Earth today. Well, number two is smallpox. And smallpox does not exist on Earth today. The only disease we've eradicated from the face of the Earth, we're close with polio, its own set of problems. But we did that, except the only two storage areas we know of are CDC and Vector Labs in Russia. And every year, every so many years, they say, let's destroy them. And we say, you know, you first, and they say us first, like little kids, and they won't destroy their supplies. But the problem is, Russia had the Soviet Union had this huge supply of smallpox. Well, when they dissolved their weapons program, what happened to all those rogue scientists that had access to that smallpox? Did they get paid millions from countries that are not favorable to us to buy some of those samples, and are they in storage? You heard that CDC had some smallpox vials. They didn't even know they were there in one of the storage facilities a few months ago. And so it's likely some of that stuff might be out there. We have enough vaccine for the entire country for smallpox. But bioterrorism is the poor man's nuclear weapon, and the right agent, released in the right way by a group with the right amount of knowledge, could be a huge threat for us. So we have Mother Nature, terrorists, and we have people, terrorists, just so we have great people and great Mother Nature. And so we have to be prepared for that. And Ebola is helping us prepare for that, because people are talking about that event that Shiriko tried to do in '93, and maybe they're going to try to do stuff like that again. It's hugely improving our ability to respond. Why we didn't do this sooner with all the other warning shots we got, I don't know. But now we have one that's really waking everybody up. So it's a great question, people are thinking about it, and we're getting better prepared for just that eventuality.
Do you know anything about the GSK vaccine for Ebola? Because I've heard perhaps another bright side is that it's being accelerated as a result of all the fervor.
It is. And there are several vaccines that are really in the works, at least 3 that I know of. And one of them is being developed at Jefferson, and it's a combined rabies vaccine with Ebola on it that's very promising in primates. So it is very likely. The problem is these vaccines that work in primates sometimes don't work at all in humans. So the large human trials have not been done yet. And really it's likely that, and hopefully one of these vaccines will be the vaccine, and probably next year it'll be proven to help. And within a year we may be using a vaccine, maybe even 6 months, that seems to show some promise, and maybe even sooner. But the vaccine developers themselves, until just recently, said probably 2 years before we have something that's gone to human trials. But if they get rapid acceleration and bypass some of the human trials and just do it on people that have a low chance of survival because where they are, then maybe even this year or early next year we'll have some human data on those drugs. But if you look at the ZMapp thing that was antibodies that was grown in tobacco plants, well, there wasn't much of that. That was 3 different antibodies against Ebola virus that had not undergone human trials yet. And of the 7 people that had it, that got the drug, only 2 people died, 7 people survived. So that's still almost a third died, whereas the current outbreak has a 50-60% case fatality rate, but that's in cases where people die at home, in Liberia. So did that 2 out of 7 represent an improvement because they got ZMapp, or is it really just because they got IV fluids, right? And so we really don't even know if that drug worked. It certainly didn't cure them all. And people are trying the antibodies to recovering people. We don't really know if you get Ebola, can you get it again? And of the 4 strains of Ebola that affect humans, we don't know if you get one, are you protected from the other? And if your antibodies do protect you in the short term, how long do they protect you for? So we really don't know if giving these antibodies are going to do anything. But in the next few months we will. And that vaccine is of great promise.
I did have just one more question. What's your point of view about with the testing by lay people at certain airports? Because it does seem like it's kind of a stretch to think that there would be laypersons who could, one, be willing to be on the front lines, and then accurately have a point of view that people are at risk.
So the people that are doing the testing at the airports.
Yeah.
So I think if you get the proper people, and proper people being trained volunteers, like we're not making any of our healthcare workers take care of an Ebola case. They have to volunteer. I don't want reluctant people being forced into their job. That's not always a good work plan. So if they volunteer and they want to help, and you train them properly, they're fine. If they force them in, and they're scared and they do this, and they're 6 feet away when they're supposed to be a foot away, then no, they're not the right people for the job. Pick the right workforce, train them, give them some reward of appreciation for what they're doing, it'll be fine. And the right screening tools.
You mentioned it was first diagnosed in 1976, almost 40 years ago. And I kind of read that on Wikipedia. I become like an expert. Obviously, you're the expert.
It's a good source of information most of the time.
But why the recent outbreak, if it's been nearly 40 years it was first diagnosed, and just again into the last 30 to 60 days?
Sure, it's a great question. So the question really, to take it a little further, if it broke out in '76 and killed up to 90% of the people in these outbreaks, why didn't we put all these resources into a vaccine and treatment back then, and then we wouldn't even be talking about Ebola today? Well, the answer is that it broke out in rural areas and self-eliminated itself. It killed a certain percent of the people, from 20 to 90%, depending on the outbreak. there was only a total of like 18 or 1900 people involved in the total outbreaks between 76 and now. And all of the dollars that have to go into research and treatment and prevention, I mean, there's a lot of other diseases that take precedent over that. There's not unlimited public health dollars. So unfortunately, Ebola was not prioritized because what's the incentive for companies to research that when nothing's ever happened to it? But now that's changed. So the main reason, it happened in a country with no ability to protect itself, in an urban area, and it's exponentially increasing. So the average for now, for measles, which is probably the most communicable disease in the world, for every one measles case, there's about 13 other people that get measles. It's airborne. And it would go into a negative pressure room. For Ebola, it's about 1.7 to 2.1, roughly 2. Every person that gets it spreads it to 2 other people in very close contact in these countries. So it didn't get the priority, and unfortunately, that was probably accurate to not put that many resources into it back then, because there were so many. HIV alone was a huge, bigger priority. Malaria, starvation. I mean, we have a long list, and you guys probably know more than I do, of world health issues that needed those dollars more, but not today.
Another question was around when you look to this consortium, let's say the global consortium to address issues in third world countries and others. Would you anticipate that probably some private sector, like Gates Foundation, would be probably more effective drivers towards getting a consortium of people together to attack something?
I think this has to be a multi-pronged attack. It's not going to be just government. It's not going to be just the priority sector or the private sector. It's going to be a combination. And yes, and Gates Foundation already has done some things. There was a talk at Jefferson from ambassadors from West Africa, I guess 2 weeks ago about. And so I attended it. And one of the ambassadors said it would only take one billionaire in the United States to cure Ebola in our country. If someone donated $1 billion and fixed the infrastructure, they felt that Ebola would be cured. So that, I think, is the best answer to your question. So if the private sector came forth with resources, and the government sector, and the world that's able to help does, not only Ebola, but every one of these outbreaks is going to be contained. And I'm hoping when the smoke clears from Ebola, that's what's left behind. And I just can't say enough about how that's the bright side of what's going on now.
Does the protective equipment that you have now, does that have a limited life expectancy if it's sitting in storage? I mean, does it have a date?
Right.
Date?
Everything does, right? And seals dry up and that kind of thing. But for the most part, our protective equipment, they give about a 10-year lifespan because, rubber seals and gaskets and something like that. But we can replace the gaskets. And for our motors, like our PAPRs are motors with a HEPA filter inside, drives it through a plastic tube into this Tyvek hood. And it's a minimum of 10-year lifespan, maybe longer, probably longer. And we test these things. We test the motors periodically. We charge the batteries every year to make sure they have a lifespan. And before I put any of the PAPR motors into service for healthcare, I charge them, then I run them to see how long they run. And on the motor, I put a sticker, on this date, we ran it, and it lasted this many hours. Because you can't send someone in for 4 hours if the battery runs out in 2, right? That would be just cruel. And so we do that. And so, yes, ideally 10 years, but we do keep these things for longer, just retest them and repair them.
I was thinking of just the protective equipment, after a certain, it would be great.
It does. And so 10 years is the ideal time, but frequently we check that. I had, for example, duct tape that we tape the gloves with, and I had stuff that I just kept in training, a box for training. And so we started digging into the bottom of the box for the training stuff, and when I went to put the duct tape on, it didn't peel off, right? Because it was old and it dried and it was useless. But we test those stuff periodically, and we run exercises every year. It's required for hospitals, and I pull out all our equipment and make sure every year that it's in good working condition. Great question.
Gentleman in the back.
I think it might be true that Ebola up until now has been constrained to Africa, and so now it's reached Europe and the US, and suddenly we're a lot more interested in finding out cures and so on. I think it was Tavis Smiley on one of the shows kind of talked about this in terms of, perhaps a racial aspect to this. But now that Nigeria is one of your shining examples, can you talk a little bit about Nigeria's pattern that they've stopped this, whether that might be some way of dealing with this for the African countries, and if that's ours too.
Right. So there's 5 strains of Ebola, including Reston from Virginia, where we had the primate breakout. So one of the strains was named after the United States breakout. And that affected primates, and it didn't spread to humans. One worker had some antibodies or something to the Ebola Reston, but it doesn't seem to affect humans. It was all a monkey disease. So it's not, the human disease has been limited to Africa, but there's no racial problem with why it wasn't treated. It's purely less than 2,000 people in a self-limited breakout is why this hasn't been dealt with before. And the fact that if it never even went to our countries, I think the resources would be thrown at Ebola now because it's starting to become such a big public health problem. So it's just that it was such a minor disease in relation to other diseases, why it didn't get the respect it probably deserved. But there are lots of other, there's not a whole lot of research going on SARS, and that was in all Western nations, and that didn't affect Africa. But no one did anything about SARS. We have no vaccine, we have no treatment. It's just that it died out, and it didn't take a lot of resources. MERS-CoV virus is in Saudi Arabia. Huge problem. I don't see a lot of discussion about the MERS-CoV virus, and that had nothing to do with Africa, and it's not in Africa. So, no, it's just that it was a disease of self-limited proportions in a world that has so many problems that we have to deal with. So that was the first question.
And then
Was,
Nigeria, that
Nigeria,
they have,
right.
really.
So no one's going to say Nigeria is the United States, but they do have a much better public health infrastructure. So they identified cases, they quarantined them, all their contacts were quarantined, and it didn't spread, just like it would happen here. So if Nigeria could do it, we can do it, right? That's the take-home point. And Senegal had one traveler with Ebola. And so they had one person that quarantined everybody, no further cases. The DRC, we don't talk about that, Central Africa. They've had about 80 cases of Ebola, a different strain that's occurring in West Africa, something like 40 deaths, no recent cases. They controlled it in DRC. So Nigeria and Senegal were just taken off the World Health countries that we have to ask the travel history for. Senegal last week, I think on Friday, Nigeria just over the weekend, and Congo, the DRC, not the Congo. DRC is going to be taken off soon because they're controlling it with just very limited public health measures. So if they can do it, do we really have to be worried about it in this country? Only if it mutates, only if a terrorist attacks us with it. But as it currently stands, no. There's no way we're going to let Nigeria and Senegal do better than we are, right? It's just our competitive spirit, if nothing other than our expertise.
Can I just ask a follow-up with regard to the congressman? Did they also have a takeaway that they should refund the NIH on research?
Yeah, I mean, I don't know how specific their take-home point is, but the message I gave them at the end was what I'm telling you guys here, that this should open up our eyes to prepare everyone for the global pandemic and increase funding and put this as number one on the government's HVA, their hazard vulnerability analysis, through all levels of preparedness. And so I didn't itemize the ones that I think that's a great one that needs to be funded, but I'm hoping they take home that message that we just have to relook at our whole response to pandemics so that we don't keep panicking every time something comes out. And that's what I think Ebola has done for us.
And one more over here. Yes.
There's no question, obviously, about the deadliness of these biological agents. The question is the delivery of these agents. And as you mentioned, they are the poor man's nuclear weapon. The Soviet Union turned to them because they fell behind in terms of nuclear weapons. But my question is this: the likelihood of someone, especially a non-government nation, carrying out a successful attack. It's, from what I understand, that spreading these biological agents isn't all that easy, and especially by a group that isn't sponsored by a national state. Is it really a serious threat that they could effectively spread this? I know there have been some things with anthrax, but it just seems that it would require enormous effort for something other than a national state.
Yeah, it all depends on what the agent is and how easy it's spread. So if they got their hands on smallpox, which is very readily spread, it would be an issue until we vaccinated the population. So if they got that, then that would be a huge threat for us. They could create weaponized anthrax, but they would need a certain level of expertise. Not a huge level of expertise, but they would have to have people that had some training in biological agents. So it all depends on the agent you're talking about. Some are more difficult than others. So for example, smallpox, we know that it has about a 30% case fatality rate. But there are all kinds of other pox viruses. It jumped from animals to people 3,000 years ago. But we have mouse pox, rabbit pox. These are all pox viruses that are just in animals. Interestingly, chicken pox is not a pox virus. It's just to mess with us and help you. But the pox viruses, so scientists in St. Louis and elsewhere in 2003 took the smallpox, mouse pox, and they genetically engineered to kill every mouse, 100% case fatality rate. They were also able to create smallpox that's resistant to vaccines. So it's possible, back even 10 years ago, to do this. So the answer is yes, it is hard, but it's not impossible. So we look at all these diseases as either Mother Nature or a terrorist group is eventually going to send us one of these agents that is a huge challenge for us and is a global threat to health. And we need to be ready, and the dollars have to be there, the research dollars, the healthcare dollars, all of those things. And if it takes Ebola to get everybody to do that, so be it.
Those of us who are old enough to have had the smallpox vaccine,
Are we safe?
is there no residual immunity left in the American population because it's been so long?
Yeah, there's actually data on that, and the Israelis kept vaccination going for a long time, and they had multiple vaccines. So for about 10 years, you're definitely good. And then the antibodies wanes after that, and so we don't know, last time was like in the 70s, I guess, that the vaccine was even given, that we don't know if today many people would have resistance to smallpox. You probably need a booster. But it is very possible that you would get a milder case of smallpox since you were exposed before. There are some diseases that surprisingly don't affect older people than younger. So normally the curve we get is a U-shaped curve for some of these agents. So if a new agent comes out, it affects the young and the old proportionally much more than the very young and the very old, more than the healthier, younger population because of our immune system. But if you look at the 1918 pandemic, it was a W-shaped curve. It actually hit the younger more, and less so in some of the older population. And it's thought that maybe they had been exposed to an H1N1 influenza sometime in the past. So they had some residual resistance. And we had, for the young people, since it was a bird flu that jumped the species, it caused our overwhelming immune system response in young, healthy people that we autoimmune killed ourselves because our immune system was so good. So, yeah, I mean, it's things we have to think about. It depends on the disease. Will depend on whether we have immunity or not. And we probably do have some residual those who got the vaccine, but we don't know how much. These are good questions.
Any other questions for Dr. Jasper? Okay, well, we thank you so much for being with us.
Appreciate being here.